for BabyChakra, and we have with us some wonderful experts, and we're going to talk about gestational diabetes today and what happens during gestational diabetes. But before we begin, let me tell you a little about BabyChakra. BabyChakra is a platform for parents to connect with experts and other parents for a better parenting, decisions, to make better parenting decisions. And we're also India's most loved online store for baby products. Um, so let's begin the session now. The doctors will introduce themselves. Dr. Neha, would you like to go first?
Hi, this is Dr. and gynecologist.
Dr. Neha, we can't hear you.
Hello,
Yes. Yes, we can hear you now.
hello. Hi, I am Doc. I am a gynecologist.
No, we can't hear you.
Hello,
We can't hear you very
hello.
clearly, Dr. Neha.
I think you should take out your mic and speak. Earphones, yeah.
Am I audible now?
Yes.
Yes. Okay. Dr.
So,
Hema, why don't you?
yes, I'll
Why don't you?
introduce. Yeah.
Yes.
I'm Dr. Hema Jaju. Should I speak in Hindi or English?
English, doctor.
English. Okay, I'm Dr. Hema Jaju, practicing gynecologist and obstetrician. It is almost since 32 years I'm practicing in this field. And most important and favorite field is high risk pregnancies, and in that the gestational diabetes is very common, and we're going to take that. And I'm working with Medicare Hospital and Research Center Indore as a consultant in the morning hours, and in the evening I have my own clinic by the name Matri Care Clinic, where I practice as a gynecologist. And another thing is I'm very much interested in menopause and adolescence, right? So this is my introduction.
That's lovely. Swati, how about you? Would you like to introduce yourself now?
So, hi everyone. My name is Swati Thoda, and I come from a background of clinical nutrition, pure clinical dietetics. So, my study has been PG dietetics and specific to do with applied nutrition. My favorite subject had always been maternal wellness and maternal nutrition right from my TY, and so I actually did some thesis work in my PG level, and that makes me more available to all the pregnant women around. And once I realized that, pregnancy doesn't end at pregnancy or, delivering the baby, it goes much beyond. And lactation care is something which was also very much precious. So eventually, I also did my certification in lactation education, and I certified also as a diabetes educator. So it just gave me an entire purview of trying to help pregnant women across trying to help them manage their gestational diabetes with much more care, trying to help them have a lovely lactation journey, because that's where women keep getting perplexed. It's not all about food, and it's not all about baby care, but it's much more about what the mother goes through herself. So trying to bring all these features and all these facets together has been a very very important part in my counseling sessions. And I've seen so much good that happens, because most often these women feel left out, because when the baby is around, the baby takes the entire limelight.
True.
Women who are going through a particular phase probably may have little less availability of people to help them out. They may be less wanting to talk about their difficulties, and that's where my role becomes very very potent, because it's, again, as I said, it's a combination of how food works, how lactation care works, how in case there is diabetes and post management of diabetes issues are. And by and by, it's more about being feeling good, right? Feeling more confident to handle that particular stage in life with much more care and with joy. So that's been my forte. So as of now, I work with Fitterfly Health Tech. It's a private digital therapeutics company where we provide wellness programs, and I work in the position of a program manager to corporate houses at the moment. I actually devise an entire pregnancy division there with the name of Pregstar, and we tried to link into pregnancy and lactation at that place. By and by, my private practice also works around lactation care. So that's been a passion, and I think that's going to be a passion for life. So here I am. Please, let's go ahead. So
Thank you
Dr.
so
Neha, you
much.
can go.
Thank you.
Yeah.
Yeah, Dr. Neha. Okay, I think
Hmm.
she has some network issues, so we'll go ahead with the session. Dr. Hema, would you like to tell the viewers what is gestational diabetes and in
Yes.
women?
Yes. See, gestational diabetes is diabetes occurring during pregnancy, right? But actually, diabetes in pregnancy has become very, very common. Why? Because in India, as such, the India has become a capital of diabetes, and so also the pregnant women. Now, the diabetes in pregnancy can be divided into two: pre-gestational diabetes, and second is gestational diabetes. What is the meaning of pre-gestational? Which is pre-existing. That means prior to pregnancy, or it is discovered in the first 3 months of pregnancy. Okay. And normally the gestational diabetes occurs in the last 3-4 months of pregnancy. So actually now our motto is to make the women aware, even especially all people, husband, family, about the gestational diabetes so that it can be detected early and the complications can be prevented.
Thank you. Neha, what is the kind of diet during gestational diabetes that and what are the things that one should avoid eating? Sorry, not
So
Neha,
as
Swati. Yeah.
Yeah, that's Swati here.
Okay,
Yeah.
sorry.
So, as Dr. Hema has explained how basically gestational diabetes occurs, it's basically that it can be a woman has not been detected with diabetes prior to her pregnancy. There could be a sudden understanding that there is presence of diabetes. So she would be a type 2 diabetes and she lands up into pregnancy, and that's where it comes into the fore.
Yes.
Else it could be that after 28 week of gestational, usually there is a compulsive OGTT test that is done by most gynecologists, and that's where in case there is, then the woman gets detected with gestational diabetes. Now, however, for a nutritionist angle, what we need to focus is why diabetes actually comes to the fore is because there is poor glucose balance in the body. So while we want to adjust this glucose balance, we have to focus on all that is bringing in the glucose into the blood. Okay, so it could be from the range of carbohydrates, proteins, even fats. All of the food that the person takes in is going to contribute to glucose at the end of the day. So
Yes.
what we want to really focus is on the entire metabolism that is happening by far the food intake. So we try to initially get to understand what is the current eating pattern of the person, what are the likes and dislikes, what is the quantum of food that they really require at each meal, because everybody eats differently, right? What are specific in terms of that particular area, the food items that are going to be available. So a broad understanding of what is the current lifestyle along with the food eating habits of a person, we try to understand. Based on this, then we start dividing the load of the meals. So what I mean by load of the meal is, it's not that we are eating only one food item at a time. So we'd be eating a combination of it, right? If I'm looking at a lunch plate, I'm going to be eating some roti, some rice, maybe also a dal and a sabzi. Some people are fond of taking salad, some others take some curd, buttermilk. There are others who include more items on their meal plate. So all of these foods combine to bring in a particular kind of glycemic load that happens in the body. Now that needs to be well balanced, right? So given that understanding, if the total load is what you say is falling within what the body is able to manage, or if the body is able to generate the amount of insulin that is going to take care of this load, then we are safe. So then the person doesn't land up into a glucose inefficient management. But in case this glucose load is higher, or if the person has been generating less insulin, then there is a reason that the glucose can become higher than 120 milligrams per deciliter at the end of 2 hours post meal. So what we want to basically focus here is try to give them an understanding that if the glucose load is going to be between 90 to 120 at all times, before or after, broadly it becomes easier for them to manage without getting into the erratic glucose balance. The higher amount of glucose in the bloodstream eventually is going to require some medication. And specifically, I am sure doctor would agree that we don't have too many medications to offer during pregnancy. So that's where, women are scared. And that's why the food management becomes a prime way of trying to help these women, keep better health. So the focus would be remaining on dividing these carbohydrates in different meals in the day, trying to see that if we are able to include some more proteins, that will give adequate proteins for the daily day requirement, and also take care of the hunger. Because if you're cutting something, you have to replace with something else. If the woman is hungry in pregnancy, she will eat anything. Whatever she is able to see, whatever she craves for, will be the first thing that is consumed. So that's where we'll have to exercise right understanding in terms of what to choose, how much to choose, and how to divide the meal such that the glucose balance can yet be maintained. So it's not about cutting food, it's trying to explain how to eat the food in the best efficient way.
Okay. Thank you. That was very informative. Dr. Hema, so you said that in India we see a lot more cases than elsewhere. So what are the causes of gestation, and why are the numbers more here than India?
Actually, see, genetically, really, we are predisposed. Then our lifestyle, then our food habits,
Correct.
right?
Yes.
These are the things which makes us prone for diabetes.
Yes.
Okay, and then what happens is if somebody in the family is diabetic, then it is going to run in the family. See what is
Correct.
happening. Whenever I take the history, either the father, grandfather, or fathers, brothers, or mothers, sisters, they are diabetic, right? When they are diabetic, so we become very careful and we screen them out to detect. And once detected, we take care of that and we continue our treatment. So we have to take care of our diet, exercise, walk, and all lifestyle modification. And then epigenetic, right? We have to change our environment also along with that.
Thank you. Does gestational diabetes affect the baby if one is pregnant and has the disease?
Pardon, I didn't get the question.
Does it affect the baby
Yes,
during
yes, yes. It
pregnancy?
affects both mother and baby. Let
Baby.
us talk about mother first. See
Yes.
what happens when she is diabetic and she is not knowing she is diabetic. So first thing is she can have miscarriages. Second, she can have congenital malformation. The baby can have congenital malformations. Then third, if the pregnancy progresses at all, right? She can have preeclampsia, that is hypertension during pregnancy.
Pregnancy.
Then the baby itself can die inside the womb of the mother because of the excessive diabetes. So these are mothers. Now baby. Baby again, we can say it's mass miscarriages. The baby can die, especially in the last months. That 9 month is very, very important. And I'm very, very particular. Every pregnant patient with diabetes, either pre-existent or during gestation, should come every 7 days to me just to see the well-being of the baby. Then baby can be very small, that is IUGR, intrauterine growth retardation. And the commonly is baby becomes very big, that is macrosomic baby. Okay, and these are the babies who may not survive in the womb, and if at all they deliver, if they are delivering normally, they can go for obstructed labor and die during the process of delivery. And even if we do cesarean section,
Yes.
there might be sometimes very difficult. It might be very difficult to take out the baby's head and the baby as such. So these are the things which we keep in mind, and then we go ahead with the management.
Also, what are the precautions that pregnant mother should take? To
See, first thing is preconceptional. If there is a history, family history of diabetes, then when they come to me for preconceptional counseling, I
yes.
tell them, please start your lifestyle modification. What will be there in the lifestyle modification? Walk, regular walk, at least 120 minutes per week,
Yes.
exercises, and then If you are obese, reduce your weight and reduce your carbohydrate. This is the first thing I do. Right?
Yes.
So, I forgot the question. What was the question?
What are
Please.
the precautions?
Precaution.
Yes.
Yeah, this is one precaution. Then, second, when they become pregnant, we give them proper yoga sessions and advices what to take, what not to take. And definitely the nutritionist comes into the play.
Yes.
So they tell them what precautions you have to take. Then in the last month, what I tell them, please take care of your baby's kick count.
Okay.
If the baby is moving normally, I tell them how it is. It should be written down, and then when you have to send it to me, and then that way I can be sure ki baby is doing okay. And then definitely I tell them for frequent visits, as I told you, and then I do even ultrasound. The frequency of ultrasound is little higher in these cases, and especially the Doppler, so that I know the baby is doing fine. And if uh, it is uncontrolled or patient is on insulin, then definitely at 37 we tell them to induce for labor,
Okay.
or if it is controlled, then 38, 39 weeks. That is the last. We tell them to continue pregnancy and then we advise them it should be induced.
All right. Thank you. So, Swati, for someone who's pregnant and has the gestational diabetes, what is the kind of diet that you would advise them to, follow?
So usually what happens, Miss Manisha, for all our audience here, I realize that people get very scared the moment they see a blood glucose level which is not in the right range. So first thing is that scare can cause more stress related up bringing up the blood glucose level. So it's important first to calm them down. Only when they are calm, they are ready to listen to the kind of modifications that I'd go out and suggest. Right. So first I do one relaxation session with them. And this has been my patent, and I've seen huge change coming in from that. A relaxation session allows the mother to think in the right perspective. So she doesn't panic, and she is able to, see through that it's not going to be a lifelong thing if she is able to make the changes now. Okay. Second thing that I go about understanding is what is her current way of living and the current eating pattern, the amount of calories, proteins, fat, etc. she is consuming rightly. Define with an understanding of her current BMI, as in whether she is overweight, underweight, or in the normal weight category. We try to define the calories which are permissible. Third thing that I understand and I tell them is to define their own goals. As in, if they feel that they want to keep their health right, I would first tell them that there is no need to gain 25 kgs in pregnancy. So, a lot of Indian mentality comes that the healthier the mother, the healthier the baby, which probably I'm sure all of us know is not true. Right. So it's important to give them this right understanding at the very start. So, if we set the expectations right, we are able to achieve the right goal. So I try to tell them if a woman is starting with an overweight category, I actually tell her there is no need to gain more than 7 to 11 kgs. One who is in the normal weight category, I tell her that even 16 kgs is just right. No, there's no need to put on beyond that. However, somebody who comes in the obese category, we don't even really need to add more than 5 kgs in her entire term time. So trying to define the food angle and the activity angle in that fashion really helps. And of course, there are twin pregnancies. There are multiple pregnancies that are happening these days because of all the IVF benefits that have come into place. So, when there is a twin pregnancy, again, there would be some additional needs which have to be catered. So, we keep going stepwise, like trimester one to trimester two to trimester three, in terms of making modifications in the nutrient that is required. So broadly, it's not going to be one chart as a pada or dedia. It has to be revised timely. Now, while we start planning calories, we also try to understand that when this lady would have tested first time for gestational presence of sugar, which means her blood glucose has gone higher than 140 after consumption of either a 50 grams load of glucose or after a consumption of a 75 grams of OGT glucose. So, if that is the way, first thing she has to understand is to know that she should not be eating that many grams of sugar at one meal or that many grams of glucose at one meal. So the easiest thing for her to understand is divide her meals. So what we do is, instead of having one breakfast and one lunch and one dinner, we try to split it into two.
So,
So that easily allows her to eat enough. It easily allows to take care of her hunger, but she's eating that same meal split into two meals. So at the end of the day, if I have to plan say 1600 calories or maybe 2000 calories for her, depending on her body's requirement, it becomes easy for me to plan a 6 meal or a 7 meal plan with the right amount of carbohydrate protein load, rather than bulking three big meals and then trying to struggle manage the glucose post load. So that's how we plan. Again, it's not all about carbohydrates coming in only from the foods, or other protein foods not giving carbohydrates. So our understanding should be that each food we consume will have their own proximate principles, right? So if I am eating a wheat or a jawar or a millet or a dal or a sabzi, everything will have some amount of carbohydrate.
yes,
So there's going to be a difference in the way it comes to the body, and the type of carbohydrate that is present. So something which is a simple carbohydrate which comes directly from honey, sugar, jaggery, maybe direct glucose supplements, etc., is direct sugar. So per teaspoon, about 24 grams of carbohydrate comes in. Now, if I am supposed to eat lesser than say 60 grams per meal, if I eat 2 spoons of sugar, it is 50 grams then and there, close to 50 grams. Then that means I am not supposed to eat anything else at the length of the
correct.
next 4 hours, right? So it becomes very difficult when you take direct sugar foods. Your body does not process it easily, right? Then in such a case, if the women are very particular and they want to keep eating sweet, they have to be put on insulin for management. But if those who are able to make smaller shifts gradually over a say period of 2 weeks, 3 weeks, with the help of a nutritionist behind, they very easily are able to split their meals, and they are able to eat more healthier than they ever could. All through their lifetime, probably pregnancy becomes the most efficiently nourished time for them, and they learn good habits now, which probably go ahead in their
Yes,
lactation phase and probably ahead in in their lifetime. So it becomes easier to arrest them becoming diabetics post delivery. We have known, there are several papers which have suggested that if a woman is gestational diabetes, at the end of 5 years there could be a good chance that she becomes a type 2 diabetic. But
correct.
if she is well managed, we can save her from getting there. So it's all about planning and getting the woman to understand that this is how it is going to be possible.
Yes,
And if she starts doing that, she believes that it is possible, and that becomes a greater help to her next generation, right? The lesser sugar load she carries now, the lesser she imprints that on her baby.
baby. Yes.
And probably we can save the environment, in days to come ahead.
Thank you so much. That was insightful. So, I mean, Dr. Hema, what puts one at the risk for gestational diabetes? Who is at a
Uh,
higher risk? Who are
yes,
the
it's
people?
all see. First is genetics, hereditary. If one parent or both parents they're diabetic, definitely you are going to have
Yes,
gestational or pre-gestational diabetes.
yes,
That is one. Then obesity. Then third is lifestyle. If you have a sedentary life along with hereditary, then definitely you are going to have it. So then these are the three things. Then if you have PCOS, polycystic
yeah.
ovarian disorder,
Okay.
that is very important. See now, 1 in 5 patients were coming to me, they are PCOS.
Oh, okay.
So yes, it's yes,
Really?
yes, in India. So PCOS patients have to be taken care of, not for the present issues, but ultimately what it is doing, it is taking us to metabolic syndrome.
Correct.
And metabolic syndrome means first is diabetes,
Yes.
according to them. Then diabetes combined with PCOS and metabolic syndrome, heart disease, blood pressure, and then further on, uterine cancers and breast cancers.
Okay.
So, if we are preventing PCOS, thereby we will be preventing diabetes. And if we are preventing diabetes, as doctor has told, we'll not be imprinting this on the baby. Otherwise, baby is again going to be diabetic, right?
Correct.
Yes.
One of our viewers wants to know what are the symptoms of uh, gestational
Diabetes.
diabetes? Yeah.
See, gestational diabetes If we have not done glucose challenge test in first 3 months, actually what is advised nowadays is glucose challenge test should be done whenever the patient comes to you in first trimester, that is first 3 months. Then second, around we do it 24 to 26 weeks, and third is 32 to 34 weeks.
Okay.
So yes, this is always done to know it. And
The symptoms, doctor.
symptoms.
Yes.
Then mother usually doesn't have any symptom. They come to us for regular checkup, and I see, yeah, its abdomen is much more bigger than the gestational age should be. Then
Okay.
I send them for a sonography and then for G glucose challenge test, and normally it comes out. So mostly they don't have any unless they are pre-gestational. If they are pre-gestational diabetes, definitely they'll be having hunger, then excessive drinking, passing excessive urine. Otherwise, I don't find any symptom during pregnancy.
Okay. Thank you very much. And, that was really informative, and I'm sure viewers have had their questions answered. Thank you so much for being a part of this live. Um, Please, and for our viewers, please download the BabyChakra app for more such interesting updates for you and your babies. Thank you.
Thank you. Thank you so much for making us
Thank
a
you so
part of
much.
this session. Yeah.
Thank you for
Thank
taking
you.
out time.
Yeah. Thank
Thank you
you.
so
Bye
much.
bye.
Thank you. I hope it's
Bye.
been good learning for our viewers. You can reach out to us as and when required via Baby Chakra.
Yes. Thank you, Swati.
Okay. Bye bye.
Bye bye.